Menstrual disturbances. Menstrual cycles are measured from day 1 of menstrual flow to the start of the next period. This reflects the changes of the uterine lining or endometrium in response to the follicular phase and luteal phase of the ovarian cycle. Most women have 28-day cycles with a range of 21 to 35 days. Normal menstrual flow usually lasts 3 to 7 days with blood loss of up to 80 milliliters. Menstrual cycles that are longer than 35 days is known as oligomenorrhea and are usually caused by anovulation. For example, women with polycystic ovarian syndrome. Conversely, older women above the age of 40 may report shortening menstrual cycles of less than 25 days or polymenorrhea caused by a shorter follicular phase. When ascertaining blood loss, the baseline loss should first be established and check if her description of her menstrual loss has increased over time. For example, a patient may report her normal menstrual flow lasting 4 days, but notice that it has now increased to 6 days with clots over the last 6 months. Corroborating this description with the fact that her hemoglobin levels are low at 8 grams per deciliter, her change in menstrual patterns, example amount of flow and duration, are clinically significant and therefore requires further workup. Conversely, a patient who complains of heavy periods for the last 2 years but has a hemoglobin of 13 grams per deciliter is less likely to have any gynecological pathology. Abnormal bleeding patterns. Some of the common abnormal bleeding patterns are menorrhagia, heavy and or prolonged menstrual bleeding. The most common causes are fibroids, adenomyosis, and dysfunctional uterine bleeding. Postcoital bleeding, bleeding seen after sexual intercourse. Some of the causes include cervical polyp, infections, and more serious conditions like cervical cancer. Intermenstrual bleeding, or bleeding between menstrual periods. The most common cause is post-ovulatory mid-cycle spotting or bleeding. However, it is important to exclude endometrial pathology such as hyperplasia and carcinoma. Postmenopausal bleeding. Any bleeding occurring in a postmenopausal woman must be taken very seriously. Tumors and cancers of the female reproductive tract must be ruled out. Irregular bleeding. Irregular episodes of vaginal bleeding, also known as metrorrhagia, is a common gynecological complaint. Do note that the so-called irregular menses should be properly described and best seen when charted onto a menstrual calendar, which will help to paint a better clinical picture. Oftentimes, the irregular menstrual bleeding may also be heavy and be described as menometrorrhagia. In this video, we will cover menorrhagia and irregular vaginal bleeding in depth. The other abnormal patterns of bleeding would be covered in other sections. Menorrhagia or regular and or prolonged heavy menstrual bleeding have a few causes, namely gynecological conditions like uterine fibroids and adenomyosis, a condition in which the inner lining of the uterus breaks through the muscle wall of the uterus. Medical conditions that may cause hormonal imbalance like thyroid dysfunctions or conditions like bleeding disorders. Medications, example warfarin or intrauterine contraceptive devices. It is called dysfunctional uterine bleeding when no obvious cause is found. When a woman complains of heavy menstrual bleeding, it is essential to obtain a detailed history of her bleeding patterns, duration, amounts, and any associated symptoms of anemia such as giddiness, easy fatigue, breathlessness on exertion. It is also important to find out about her medical and family history as well. Important physical signs include conjunctival pallor, low blood pressure, and rapid heart rate. Additionally, do an abdominal examination to detect possible pelvic-abdominal masses. In a woman who is a non-virgin, use a speculum to exclude any pathology in the cervix and vagina, such as polyps or abnormal growths. Lastly, a bimanual assessment of the uterine size and shape are also important in a non-virgin woman. Classically, an irregularly shaped uterus would suggest fibroids, while a regularly enlarged uterus would suggest adenomyosis. Do a full blood count to check her hemoglobin. A pelvic ultrasound would be useful to confirm the presence of fibroids and for adenomyosis. If you suspect any thyroid dysfunction, a thyroid screen may be done. Principles of management include measures to stop bleeding and increase hemoglobin levels. It is necessary to stop the bleeding if the woman is presently actively bleeding and is anemic. This is common as most women would delay their visit until the bleeding or anemia becomes physically intolerable. The progesterone norethisterone is commonly used and given 10 mg twice or 3 times a day. After taking the drug, the bleeding should start to reduce within 24 to 36 hours. Hematinics should also be given to replace her now severely depleted iron stores. The patient should be kept amenorrheic by taking norethisterone until her hemoglobin levels improve. As a guide, her hemoglobin should increase at a rate of 1 gram per deciliter per week, provided that the compliance and absorption is good. Once the hemoglobin level returns to normal, the hormonal medication can be stopped and withdrawal bleeding will occur in the next few days. Medications can be prescribed to reduce her monthly flow. The following medical treatments can be used to reduce a woman's monthly heavy menstrual flow. Non-steroidal anti-inflammatory drugs, NSAIDs. This helps to reduce menstrual blood loss by 20 to 30% and is best started 1 to 2 days before the heavy flow is expected. Once the flow is tailing off, the medication can be stopped. An affordable and effective NSAID would be mefenamic acid 500 mg taken every 8 hours. Tranexamic acid can be taken to reduce blood loss by 50% when started on the first day of heavy flow. A dose of 1 gram every 8 hours is commonly used and taken only during heavy menstrual flow. A combined oral contraceptive pill can reduce blood loss as well as provide effective contraception. Do note that the medication needs to be taken regularly for 3 weeks for it to be effective. The woman should be counseled on the pros and cons of using this option. Please refer to the video on hormonal contraception for more information. Mirena or levonorgestrel intrauterine system may be used and it releases 20 micrograms of levonorgestrel daily, providing effective blood loss reduction of more than 90% and contraception for 5 years. However, do note that this treatment is associated with irregular episodes of breakthrough bleeding and 1 in 5 users may have no bleeding. Dysfunctional uterine bleeding, DUB. Dysfunctional uterine bleeding, DUB, is diagnosed after excluding other causes. It is defined as bleeding from the female genital tract, for which no cause can be found on physical examination and investigations. There are 2 main types of DUB, anovulatory and ovulatory DUB. Anovulatory DUB is uterine bleeding due to absence of ovulation. In adolescence, the hypothalamic pituitary ovarian axis or HPO axis is still immature while the ovaries are full of follicles. The adolescent presents with irregular cycles or periods of amenorrhea followed by intermittent or continuous heavy vaginal bleeding. However, with time, the HPO axis matures and she begins to ovulate and settle down to normal regular cycles. For perimenopausal women, usually after 40 years, their ovaries are generally depleted of follicles despite a mature HPO axis. These women have irregular bleeding until they reach menopause. Do note that it is important to actively rule out any abnormal pathologies of the female reproductive tract. Irregular anovulatory cycles in women in their childbearing years between 20 to 40 years old are less common but can be commonly encountered in women with polycystic ovarian syndrome. Alternatively, any severe stress or significant weight changes can cause a woman to start having irregular menstrual cycles. Ovulatory DUB is most often seen in women in their childbearing years. This is often due to early degeneration or prolonged function of the corpus luteum. The typical history is often of premenstrual spotting or prolonged spotting after a menstrual flow. Irregular vaginal bleeding. When looking out for causes of irregular vaginal bleeding, it is imperative that pregnancy be excluded. Missing an ectopic pregnancy can result in serious morbidity or even mortality. Abnormal growths and polyps arising from the cervix and uterus are also important causes. The main causes of irregular vaginal bleeding are shown here. Investigations. The following tests may be offered to the woman to determine the cause of irregular vaginal bleeding. A urine pregnancy test is critical in ensuring a pregnancy complication or ectopic pregnancy is not missed. Ensure that the pap smear is done with the cervix well visualized during the speculum examination to avoid missing a large polyp or cervical malignancy. Endometrial sampling using either the pipelle or at dilatation and curettage is important to exclude endometrial pathology such as hyperplasia or cancer. This is generally recommended for women above the age of 40 with heavy irregular vaginal bleeding. Younger women, especially those with polycystic ovarian syndrome, may also need endometrial sampling due to their chronic anovulatory state with unopposed estrogens putting them at risk of endometrial hyperplasia and cancer. Blood test for follicle-stimulating hormone, luteinizing hormone and prolactin, which are useful in uncovering hormonal causes of anovulation. Thyroid screen can be checked if thyroid dysfunction is suspected. A transvaginal ultrasound for non-virgins is useful in diagnosing polycystic ovaries as well as detecting endometrial polyps or thickened endometrial linings with cystic changes suggestive of endometrial hyperplasia. Clinical management. The clinical management of patients presenting with irregular vaginal bleeding can be summarized into 3 steps. Step 1. Ensure that you exclude any pregnancy and abnormal growths by carrying out the appropriate tests. Step 2. Stop the acute bleeding. As mentioned earlier, women would need norethisterone and hematinics. We may also need blood transfusions if hemoglobin levels are low, less than 7 grams per deciliter, and the patient is very symptomatic. The patient should be kept amenorrheic with continuous norethisterone until her hemoglobin level improves and she feels symptomatically better. Step 3. Medical treatment. For the adolescent with anovulatory irregular cycles, cyclical progestogens like norethisterone can be used. Doses of 5 to 10 milligrams daily, taken for 12 to 21 days, can be used. A simple plan would be to take the medication from day 1 to day 12 of the calendar month. For a woman of childbearing age with irregular anovulatory cycles, management would be dependent on her fertility wishes. If the anovulatory woman has polycystic ovarian syndrome but is keen on childbearing, ovulation induction medications may assist to regulate the cycles by increasing the chances of ovulation and conception. However, if she's keen on contraception, then the oral contraceptive pill would provide effective contraception while ensuring regular withdrawal bleeds. For perimenopausal women complaining of irregular bleeding, cyclical progestogens can be used once hyperplasia or cancer is excluded. A simple regime of 5 to 10 milligram dose of norethisterone daily for the first 12 days of each calendar month will regulate her cycles. Thank you for watching this video. This video is presented by Yongloo Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.